Thank you very much. Thank you very much, and thank you to the organizer also for inviting me to talk on this important topic, which is actually evolving for the last couple of months. So we were not much discussing about the obesity because of the fact we did not have much drugs to address the obesity. Now we have few, and we also find that there is a progressive rise in the prevalence of the obesity. Now the Indian actually have progressive rise in obesity, so much so that almost 1/3 of our population actually have the obesity. So what I want to tell you first, that in our country obesity is glamorized. Glamorized means that we feel that healthy means obesity. When I was a child, my mother used to tell that they see that the other boy in the next house is very healthy. So actually that boy was overweight or obese. So that's a important issue, that we actually say healthy as in obese or overweight person. And that narrative must change, because you know that the obesity is associated with lot of complication, especially when we talk about the complication, the cardiovascular complication. We need to understand that 1/3 of the world population die because of cardiovascular disease. Not only world, but also in our country. So obesity actually increases the 50% chance of dying from cardiovascular disease. And we actually glamorize obesity by saying that this person is healthy. So that narrative must change. So the first question is that whether obesity is a disease or not. As I've already said, a lot of comorbidities are associated with obesity, and if you look into the multiple organization, WHO, AMA, Endocrine Society, they have said that obesity should be recognized as a disease. So this must pass on to the general population, general people, that we should consider it as an obesity. I find that the people with a blood sugar level of 133 fasting come to me, doctor, I have diabetes and please treat. People who have cholesterol of say LDL 140 may not need any treatment, but come, doctor, I have high cholesterol. But nobody come to me, doctor, I have 5 kg overweight or I have 7 kg overweight. No, I have not seen in my lifetime that anybody came with 5 or 7 kg overweight. But yes, they come if they 25, 30, 40 kg overweight. Then that's a separate issue. But first of all, what is the definition of obesity? We all actually measure obesity in the form of, say, BMI. But I know there are a lot of fallacy of BMI, and I must tell you that the commonest complication or the most important complication of obesity is the cardiovascular disease, which is not much linked with BMI rather than linked with the waist circumference. In our clinical practice, in our chamber, we measure height, weight, BMI, but we never measure waist circumference. So it is the time or high time that we start measuring the waist circumference to define the people with central obesity. Now there are a lot of causes of the obesity. I will not go in detail because you had the topic discussed before. We have multiple endocrine causes like hypothyroidism, the Cushing syndrome, the pseudo-hypoparathyroidism. We have some monogenic obesity, and there are a lot of syndromic obesity as well, but these actually constitute only a small fraction of total obese population. And what the commonest cause of obesity, as you all know, is basically because of excess calorie intake. So if you take good amount of calorie over the energy expenditure, there is a possibility of weight gain. This is one of the heaviest patient in my chamber. Now if we look into the obesity and the disease, the most important concern in front of us is the insulin resistance. Why the obesity develops the cardiovascular disease? The important reason is that the many people with obesity actually have insulin resistance. So that is basically an important issue, because if we look into the obese people, 70-80% of the obese people actually have insulin resistance. But at the same time, I must tell you, the another 10, 20, 30% patient actually do not have insulin resistance. So that we need to understand. So therefore, if we look into these two important persons, you can see they both of them actually have the same BMI, almost same BMI, but one is having waist circumference 121, and there is 81, and you can see the profile is quite healthy here, and the profile of this person is actually quite unhealthy. So that actually is the difference between the healthy obesity and unhealthy obesity. So if we look into the aspect of the obesity, the 20% people, those who are metabolically healthy, they have actually low visceral volume, and they have low liver fat content, and they do not have much inflammatory markers. And also, on the other hand, the metabolically unhealthy obese people have got more visceral volume, they have high liver fat content, and they have insulin resistance, they have a higher inflammatory markers, and they are prone to develop, the so-called cardiovascular disease and cardiovascular event. So, if we look into the prevalence of the cardiovascular event and also the all-cause mortality and diabetes mellitus, you will see that the people with metabolically unhealthy obesity actually much higher chance compared to those who are metabolically healthy. So if we look into the patient in your chamber, you will find not only the waist circumference, but acanthosis nigricans and skin tags are two important markers which will tell you that these patients actually have insulin resistance, even though you are not measuring in the lab. And because of this insulin resistance, you will find that the people with overweight or obesity, they develop ectopic fat deposition. And I believe that the four important organs which are very, very important when you are considering the ectopic fat deposition. One is pancreas, second is heart, third is liver, and fourth is the kidney. So these are the four organs which actually mostly suffer when there is an ectopic fat deposition and leads to a lot of important diseases. Now, if we look into the adipose tissue, how they respond to the excess amount of calorie intake, the people with the metabolically healthy obesity, there you will find that adipose tissue undergo hyperplastic change. It means their number is increasing. On the other hand, people with unhealthy obesity, they actually have adiposity hypertrophy or increase in the size. So one is increase in the number, another is increase in the size. If somebody have increase in number, then there is no question of impairment of the blood supply, and therefore they can accommodate more fat in the hyperplastic cells, and they usually produce some positive signals, adiponectin, leptin, and FGF21, and they actually lead to metabolically healthy obesity. On the other hand, those who undergo adipocyte hypertrophy, then there will be impairment of the blood supply, and there will be hypoxia at the level of the adipose tissue, which leads to the development of inflammatory cytokines, and these inflammatory cytokines are actually responsible for the development of cardiovascular disease or other disease. So this is the patient with healthy obesity. You can see that the adipocyte actually producing these three important adiponectin, leptin, the fibroblast growth factor 21 leads to the increase or improvement in the insulin sensitivity. On the other hand, atherogenic signal from the adipose tissue occurs if some adipose tissue, if undergo hypertrophic changes, they produce tumor necrosis alpha, the interleukin 6 resistance, and free fatty acid, and all these actually impact the important organs, leading to different comorbidities associated with obesity. So then comes the question of the debate. So the people, those who are metabolically healthy, should they require any treatment? Or we should prioritize the treatment of metabolically unhealthy people with obesity rather than those who have metabolically healthy obesity. So therefore, that debate is still on and we don't have the answer. So as I've already said, that the health impact of the obesity, I'm not talking about the cancer, I'm not talking about osteoarthritis or talking about the increased possibility of gallstone disease, but as I've said, the four important organs which actually we consider endocrinologists are very important to us. One is pancreas. Few gram of fat in the pancreas is responsible for the beta cell defect and leads to the development of diabetes mellitus, or I must say one of the important reasons for the development of diabetes mellitus. The one important person, the Roy Taylor, who had done an excellent study showing that if you can reduce that few gram of fat from the pancreas, there is a reversal of the diabetes, which has been established. And now if you look into the other organs, the the adipose tissue associated kidney disease, heart disease, and as you know, metabolic associated fatty liver disease are quite common. So if you look into the weight loss program, if there is some degree of weight loss, then you will get some benefit. Higher the weight loss, higher is the benefit. But at least 5% weight loss is necessary to get some benefit in the state of hyperglycemia. 5 to 10% weight loss leads to improvement in the non-alcoholic fatty liver disease. A 10-15% weight loss leads to the improvement of NASH hepatitis, and more than 15 or 20% weight loss leads to diabetes reversal. So therefore, any degree of weight loss is important. Higher the weight loss, higher will be the benefit. And therefore, most of the people do not want to do the lifestyle modification, and therefore they ask this, why should not take just a pill? Now, till recently, we have only few oral drugs, anti-obesity drugs available to us. Now, this is the only drug available in our country right now is the orlistat. Very recently, the naproxen bupropion combination has been actually marketed. What I mean to say, don't look into the cosmetic effect of the obesity. How much weight loss is happening? These drugs actually cause weight loss of 5%, 8% or something like that. But we need to see whether these drugs can give benefit in the 4 important complications which I am talking about the diabetes, whether they improve the metabolic associated fatty liver disease, are they good enough to prevent the cardiovascular complication of obesity? These are the important questions, not the cosmetic effect of the obesity. Now, if we look into the long-term cardiovascular outcome trial with the orlistat therapy, though there is no dedicated cardiovascular outcome trial is there in orlistat, but this is basically a cohort study from UK showed that it significantly improved the major adverse cardiovascular event. However, we now have basically a number of medication which can actually reduce the body weight. So liraglutide, semaglutide, dulaglutide, and these GLP-1 receptor agonists are nowadays used as an anti-obesity drug. And you can see all 3 drugs actually shown the significant benefit as far as cardiovascular event and mortality is concerned with LEADER, STEP, SUSTAIN, and REWIND trial. The liraglutide and semaglutide are approved as anti-obesity drugs, but dulaglutide is not yet approved. Now, we have a few years back, we have done this study. We have actually done this study and also looked into all other Indian studies, and we compared the weight loss benefit with liraglutide. We have not used the liraglutide as an anti-obesity dose. We have used liraglutide as anti-diabetic dose, 0.6, 1.2, 1.8 milligram dose, and we have found that the liraglutide in Indian subset produces more weight loss, 4 kg to 6 kg in different Indian studies, including ours, compared to the lead study, which is basically Western data. So, what we understand that these GLP-1 receptor agonists are actually more beneficial in Indian subcontinent as far as the weight loss is concerned. Now, if you look into liraglutide, this 3 milligram dose in the Western study, it reduces the weight loss of 8 kg, roughly around 8 kg, which actually we achieve with the liraglutide of 0.6, 1.2 or 1.8 milligram dose in our country. And if you look into the study output, is 1/3 of the patient actually achieves the 10% weight loss. Looking into semaglutide is a far better drug which we are yet to receive. This with this dose, 2.4 milligram dose, you will find that the weight loss is almost 15%, 16%, 17%. So better than the liraglutide, whatever we have. But the issue is GLP-1 receptor agonist. If we look into the meta-analysis, all the GLP-1 receptor agonists, if we consider together, they are not only associated with the cosmetic effect of the weight loss, but they are associated with benefit in all-cause mortality, major adverse cardiovascular event, composite renal outcome, and that goes without saying, it has benefit in major metabolic associated fatty liver disease as well. Now, recently we have these 3 drugs, tirzepatide, retatrutide, and orforglipron. I think the retatrutide and orforglipron is not yet available, but it will going to be available within near future, no doubt. So therefore, be ready for these 2 drugs which are going to be available. Tirzepatide is now available in our country as well. And you found in a SURMOUNT trial producing 22.5% weight loss. So what I am showing you, that the oral drug used to produce a weight loss of 5%, we have GLP-1 receptor agonists. They produce say 10%, 15% weight loss. Semaglutide is producing roughly around say 20% weight loss, 18%, 20%. Here is tirzepatide producing 22.5, and the maximum weight loss was actually shown with triple agonist GLP-1, GIP, and also glucagon receptor agonist, that is 24.2%. So if we look into head-to-head between semaglutide once weekly and tirzepatide once weekly, you will find that the tirzepatide actually beaten the semaglutide with even with a 5 milligram dose of tirzepatide is better than the semaglutide as far as the weight loss is concerned. However, let me tell you that the semaglutide was used as a 1 milligram dose and not as 2.4 milligram dose. But if you look into beyond the cosmetic effect of the weight loss, I can share with you that the cardiovascular outcome with semaglutide is excellent with 20% risk reduction. The cardiovascular outcome with tirzepatide is not yet available, is going to be available in 2027. The kidney outcome in the SELECT trial and tirzepatide also showed benefit in the long-term kidney outcome trial. And if you look into metabolic dysfunction associated steatohepatitis with semaglutide and tirzepatide also shown the benefit. So therefore these drugs not only have the cosmetic effect but also have effect beyond the cosmetic problem. That means the heart, kidney, liver, as well as the diabetes mellitus. Very recently this SURMOUNT-5 trial has been published only a few weeks back, and you can see this actually showed that the semaglutide, tirzepatide is better than the semaglutide, with a 20% reduction with tirzepatide and 13% reduction with semaglutide in a head-to-head study. So my take-home message is that the commonest cause of obesity result from calorie intake exceeding energy expenditure. People, those who are telling jol khelo mota hoy, they are wrong. People are eating and that is why they are getting obese. Number two, that the metabolically unhealthy obesity is associated with increased risk of diabetes, kidney disease, fatty liver disease, and cardiovascular event. And therefore we should, when we are looking into any anti-obesity drug, we should not look only into the cosmetic effect of the drug. We should look beyond that, whether this drug is giving benefit in the other aspects of the obesity or not. And glycemic efficacy and weight loss with liraglutide seen in Indian studies is far more impressive than seen in lead trial. This is our own experience which we have published. And GLP-1 receptor agonists have shown significant benefit beyond glycemic control, especially in cardiovascular, renal, and hepatic outcome. And semaglutide is more effective than liraglutide in weight loss, and tirzepatide is more effective than semaglutide in weight loss. And lastly but not the least, retatrutide is more effective than tirzepatide in weight loss. Thank you very much for your patient listening. This is my photograph in Everest Base Camp Trek. Thank you very much.
Thank you.